Welcome back to the Action Collaborative's virtual symposium. Our next session will focus on pain management guidelines and evidence standards, the importance of accessible and effective pain management in combating the opioid crisis cannot be overstated. It is a critical aspect of the response to the epidemic and is also essential to ensuring quality person-centered care. I am delighted to introduce the participants taking part in today's session. The Pain Management Guidelines and Evidence Standards Working Group is led by our two co-leads, Dr. Helen Burstin, who is the Executive Vice President and Chief Executive Officer of the Council of Medical Specialty Societies, and will be leading our presentation today. And our second co-lead is Dr. Debra, Houry, who is the Director of the National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention. Joining our co-leads for the session today are our expert panel of reactors, Ms. Sally Okun, who is an independent advisor and consultant on projects related to patient and public involvement in research, care, policy, and ethics. Dr. Rahul Rajkumar, who is currently the Chief Operating Officer at Optum Care Solutions, and Dr. Kara Odom-Walker, who is the Senior Vice President and Chief Population Health Officer at Nemours. Their full biographies are available on the event website for you to access. And now I will turn things over to Dr. Burstin.
Thanks so much, Aisha, and delighted to be here, especially with Deb, my co-chair, who will jump in to the presentation as needed. And we're really looking forward to the reactor panel at the end. We've had an extraordinary working group that has worked well together, multidisciplinary, and very much invested in hearing the patient voice, as you will hear as we talk about our work around the journey map. Just lastly, want to thank Cassandra for that just tour de force this morning. That was, I think, in many ways will influence and reshape the way we think about our work going forward. So just thank you for that presentation. So let's go to the next slide, please. So we want to just give you a little bit of orientation to what our goals were overall for the Pain Management Guidelines and Evidence Standards Working Group. We really wanted to think about how we could highlight and advance opportunities to strengthen pain management, very much looking at it from both a patient-centered and an evidence-based point of view. We focused on tapering guidance, multidisciplinary pain management, and really thinking about how we can judiciously, and that's a really important word there in our mission statement, implement pain guidelines into practice. And we've in fact taken a lot of pains, no pun intended, to ensure that there have not been unintended consequences, in fact, from some of the guidelines that have been put forward. Our objectives is to really identify where there are best practices, particularly around tapering opioids, as well as indications, and particularly some of the newer work around acute indications that has just been released. Looking at how we can highlight evidence-based approaches to integrative pain management and how we can help support their broader implementation. And finally, as I mentioned, really thinking long and hard about how pain guidelines get put into practice, and while we're monitoring for both intended and unintended consequences. And obviously having Deb on our team here has been invaluable since so much of that work has come out of her shop. Next slide. So let me go through a couple of the achievements, and we've still got a lot of work to do, but at least where we've gone so far. So first, we have published a discussion paper that synthesized best practices, research gaps, and priorities for tapering opioids for chronic non-cancer pain. We then convened a series of clinical experts and persons with lived experience through a variety of mechanisms listed here to hear from their point of view, what are the barriers and what are the opportunities for us to improve pain management and care delivery. We did a webinar, again, focused on tapering with some different patient or cases to help highlight some of the important nuances and gaps in research policy and practice. And then really importantly, we did a series of what we called listening sessions, where we featured, for example, patients with chronic pain to capture their experience, their lived experience of going through and navigating the healthcare system while having chronic pain. And we also did a listening session with a group of clinicians, pharmacists, physicians, and others to understand from their perspective as they treat and manage patients with chronic pain, what are the issues they're facing, what are the barriers they face, what supports do they need? And then finally, and really I think the piece we're most excited about moving forward is this idea of creating a person-centered journey map. Our hope is that that will really help bring forward individual clinician and health system level insights, as well as strategies and opportunities to improve care pain management. So I should mention in advance that we pushed hard to have the draft visual included in this presentation for those of us who are visual learners, but just keep in mind it is very, very much a draft, but we thought it'd be important for you to see it as we move forward. Next slide, please. Great. So just quickly going through each of these quick achievements. The first I mentioned is the discussion paper on opioid tapering. We'd really welcome your feedback on that. It is published on the National Academy site. We really tried to focus on what were those key decision points, where's the available evidence, where do we need more evidence, and then thinking about where there are opportunities around non-pharmacologic treatments, understanding from the patient perspective issues around tapering, looking at interdisciplinary teams, as well as some other potential therapies here to help patients and clinicians move forward on tapering. We recognize this is not without controversy in the patient community, and we would try to be very sensitive to those issues. Next slide, please. We really, I think, look to this concept of a patient-centered pain management journey map as being the culmination for a lot of the individual efforts we have put together to date. What we're really trying to do is create a visual that will be alive. It won't be just on paper, but something patients, clinicians, and others can go to help really explore and illustrate the lived experience of patients who have been on long-term opioids for chronic pain, going through a taper, what they need from clinicians in the broader health system. As I mentioned, the product of this really does come out of the patient listening session, as well as the clinician listening sessions that we did to help create this person-centered journey map, which is really a visual illustration of the chronic pain journey. And we hope it will help illustrate where there's clear evidence, where we need more evidence, where more work needs to be done, and also help us identify both practice and system level gaps in chronic pain management. Next slide. So here are some of the key points that we heard. We took the information both qualitatively and quantitatively from the listening sessions that we did and the surveys. I think we had almost 500 surveys submitted by patients after the patient listening session. We had an external research team pull those together, analyze them into key themes around knowledge, partnership, and support that emerged as being some of the key pieces and the basis for the map that we'll show you shortly. And then given these key themes, we really wanted to emphasize that the patient is at the center of this journey map. Their experiences, their perspectives really help elucidate the key findings and the structure of that map. And again, even though we've called it a journey map, it's not a traditional journey in any sense. It's very, there's lots of turnoffs and probably circular logic in some ways, but we want to ensure that for patients that it communicates that there's a series of these key touch points of the key themes with clinicians and the broader health system, and try to focus on what good looks like, and while recognizing that there are many challenges that remain. So next slide. So as I mentioned, a static version will be available to download, but the online version we're working on will be more interactive. It'll link to tools and resources that address patient and healthcare system needs, healthcare team needs. For example, we've had some really interesting work done for clinician decision support around some of this that we will be able to build into this work. And I'll also link to reports and other findings that support the opportunities for how we can broader address what are really system level challenges. Ultimately, we'll hyperlink it so that you can actually go back and dive deeper for anybody who wants to get more in-depth discussion. Next slide. So again, with all the caveats I've promised, here is sort of a visual of what we've put together so far. And thanks to the team for doing this work. Very much, again, emphasizing this is in draft form, but living with chronic pain, understanding a patient's journey. And I want to highlight some of the key things we've left here. The patient and their needs, their experiences and expectations are at the center of this map, and they inform the content of the map. We have 3 central themes that are listed there, and each are connected to the clinician level and or health system level insights. And really this gets organized into what we know is working well, what we still know needs improvement across that full continuum. We've also identified some cross-cutting barriers such as disparities, and I would add in structural racism here, and issues such as stigma and bias. And based on the collective insights we've gathered to at least start putting this MAP framework together, we've started to identify the tools and resources that will be needed for both patients and clinicians. And you can see them called out here on the right as a starter set, as well as key needs and opportunities for broader health system improvement that are pretty hard to read there on the lower, on the bottom right. So over the next few slides, we'll go through this in a bit more detail, but just to give you an overall framing of how this came together. Next slide, please. So the basic outline here, it builds off the framing prompt, which is what I need in my pain journey, which was the question that we asked as part of the patient listening sessions. And as I've mentioned, it's organized around the patient's needs, around knowledge, partnership, and support, which was the key themes that emerged out of that work. And then the insights at both the individual patient, clinician, and health system levels all connect back to those three core themes. The first section of the map is focused on knowledge and the need for patients to feel informed about their condition, with a couple of key insights listed here. For example, the clinician level, making sure there's clear, compassionate communication, including issues around stigma, strategies to maintain transparency, effective tools for shared decision-making. At the health system level, the need for accessible patient-centric resources, as well as knowledge and access to a range of specialists. Next slide. The next section of the map focused on partnership and the need to really emphasize that all of this work has to be done with a strong patient-clinician, I would say here, relationship. Key insights really need to go back to training tools and resources for clinicians to improve communication. Our work group, for example, had a lot of discussion about the importance of language, and we heard some of that from Cassandra earlier today as well. Building trust, prioritizing quality of life goals and strategies to address stigma against pain and opioid use. And the last section of the map is really about support and the need for patients to be supported through community resources and access to a range of medications and other therapies. So at the clinician level, how do we build awareness and connections to support patients as they try to get to some of those other alternative therapies that are evidence-based? How do we make sure that there's in fact appropriate reimbursement and payment for using those non-opioid evidence-based strategies? At the health system level, for example, how do we ensure that there's access to those medications and therapies as well to optimize pain treatment, improve coverage and access similarly, but to that really that broader range of multimodal care, while always thinking about how you support the patient in front of you for more individualized care. Next slide. Because of the pandemic and what we've all experienced, it is so obvious, and we'll talk more about this across all the work groups, that telehealth has emerged as such an important topic. And we've had a lot of discussions in our working group about how, for example, pain management guidelines change or morph in a telehealth environment. So we've also tried to include in it some key touch points across pain-centered pain management and care, and we'll embed it across the map to think about where we might be able to build in some of those access improvements and think about how it may influence both guidelines and quality metrics. For example, on one of our calls, we had a discussion of, how do you handle urine testing in a telehealth environment? Lots of really important questions we're going to need to think about going forward. Additionally, as I mentioned, there were a series of these cross-cutting themes we've embedded through across the three themes in the map. Disparities, and I would again add in here really importantly, really structural racism, and then lack of equitable resources across diverse patient groups, attitudes, biases, stigma, and I'll also add in from the comments, again, from Cassandra this morning, thinking perhaps as well about patients who have polydrug use, since this has been so focused on pain management, but really making sure we keep those issues front and center. And then lastly, it's essential to make sure that the impact of these factors and the need of these prioritized solutions moving forward. So very, very much a work in progress, but very much informed by what we heard by listening to patients and clinicians. Next slide. So a few other future directions to share, and then we'll open it up for discussion. We're going to continue to build on our prior work. And again, thanks to Deb, thanks to our just extraordinary working group and the amazing team at NAM who's been helping us do this, build on our prior work in pain management by really thinking about how we can accelerate the the resolution of some of the clinical practice and system level gaps we've identified in chronic pain management, and thinking about how we can advance those evidence-based clinical practice guidelines, particularly for acute pain. And some of you may have seen some new recent evidence reports that emerged out of AHRQ, CDC, and others. So specifically, we'll look to disseminate and address the critical findings and challenges across the chronic pain portfolio through these targeted tools and resources. And then finally, think about how we can coordinate and catalyze across our member organizations and their networks to strategically advance, and I would add in here, very importantly, harmonize some of the emerging clinical guidelines for acute pain, because we've seen so much of the use of opioids for chronic pain really begins at the front end with perhaps overuse of opioids or any inappropriate indications for opioids at the start. So I believe that is my last slide. I'm going to quickly, just before we get to the panel, open it up to Deb to see if she'd like to add anything.
I think you really hit on everything, Helen. Thanks for that great summary. And I want to echo your thanks to our awesome work group and the NAM staff. The journey map, we shared that draft visual, and it's hard to read because it's certainly small print, but our hope is that it's not just a piece of paper, but a living, breathing tool. And so when we've been looking at a lot of our things, whether it be the opioid tapering paper or this journey map, we really envision them as being tools for clinicians and for patients. And that's why we've really tried to have stakeholder input into this. And the journey map, when we initially talked about this, we saw it as where you would enter into the map and kind of proceed across it. But we realized that that's really too simplistic when we're looking at things like chronic pain and tapering, and that we needed to really just focus on key areas and themes.
Great. Thanks so much, Deb. And as you'll hear shortly from our reactors, and thank you so much to Sally, Rahul, and Kara, we'll bring in a really wide range of perspectives, the patient perspective, actually Sally as well, the nursing perspective, Rahul bringing more of the payer perspective and clinician, and then Kara has this extraordinary background of having both been a health commissioner in Delaware and now working in a health system. So we really are looking forward to getting their input as we think about how we can continue to move forward, and especially any of their insights around the journey map. So Aisha, turn it back to you. Oh, I guess there we go. Thank you.
Thanks, Dr. Burstin and Dr. Houry. Really appreciate your remarks. With that, we'll go ahead and get started with our reactor panel feedback. We'll start with Ms. Okun, and then we'll move to Dr. Rajkumar, and then end with Dr. Walker before breaking into our discussion.
Great, terrific. Well, first of all, let me thank you so much for the opportunity to participate in this really important discussion. It's been an amazing morning so far. And I really want to applaud the work done today to develop a person-centered journey map informed by patients and clinicians. Indeed, the goal of this journey map is no small undertaking. So I'm going to focus first on some remarks around the journey map, and then second, look at some of the future directions for research that could be prioritized. So we learned from Helen that this is not a traditional journey map, but rather it's going to hit on key touch points of central themes that emerge from the listening sessions of knowledge, partnership, and support, while also highlighting good care and areas where opportunities for improvement remain. So with that in mind, I think it's really important to recognize how this will evolve over time. The non-traditional approach, however, might require more explanation, since a journey map generally does suggest the visualization of processes and activities involved to reach certain specific goals along a timeline that ultimately come together to form a visual narrative. The current iteration actually seems a bit to me like a Google map, where relevant places and routes and points of interest are highlighted, and where you could zoom in for more detail. Similar to what I think is keeping in mind the dynamic online version of something like this might be, where you could zoom in to see a bit more about the tapering experience. I could also imagine a dynamic way to get directed to specific points that would flow along the milestone-oriented view of a more traditional journey of living with chronic pain, or even the experience of acute pain at some point, and the tapering experience as well. I must say, as I moved around the map, I found myself getting a little bit lost. There's lots of text, and Helen's already recognized it's right now quite small. But I also found that some of the icons weren't intuitive to me, such as stigma and bias. They didn't quite resonate with those two terms when I looked at them. Right now, the patient icon on the left is really big and takes up quite a bit of real estate. So it's an opportunity to do some redesign on the graphics there. But at first glance, I actually didn't connect the relationship of that patient in the space running through the center of the three circles. Once I grasped that, I could see how the small patient icon was actually seemingly moving through the circles and presumably interacting with clinicians in the health system to meet their knowledge or partnership or support needs. However, I would expect that the patient's needs are going to ebb and flow. And so that should probably be more multi-directional for a better understanding of the ways people might experience it. I would recommend adding patients. And when I say patients, I'm also including caregivers and peers in the circles themselves to represent their role and contribution to knowledge, partnership, and support. I would suggest also that on the center one under partnership, health system isn't included there. And in fact, I think that they have a large role in enabling collaboration and communication when multiple providers might be involved in this part of the patient's experience. You know, I totally appreciate and respect how hard it is to illustrate the many dimensions and multi-stakeholder experiences of a very, very complex process. I've no doubt that the evolving iterations and with input from things like what we're doing here today will help to improve its optimal usability. But I think some of the attention paid to ways where that future dynamic view can come in and out of the experience in a much more useful way, I think would be really quite remarkable. And lastly, I will mention that we actually did some interesting work at Patients Like Me on creating a patient caregiver journey framework that was published in the Learning Health Systems Journey. And in the process of preparing for this session, I actually came across a rather interesting visualization titled Patient Information Journey, created by a company called Blue Latitude. And I'll be happy to share those with the collaborative. I did put them together in a PDF so that you can have those. And then I'll shift now to the second part of the discussion that I was asked to consider, and that is what are some of the future research and actionable strategies that we might prioritize from the patient perspective? And I focused on three, and I focused on those because I think that they provide the greatest opportunities for leveraging real-world data in the management of chronic pain and tapering that reflects patient, caregiver, and peer involvement, and includes the potential for creating really honed-in patient-informed outcome measures. So the first one was determine the optimal non-opioid and pharmacologic and non-pharmacologic approaches to managing pain in different populations. And my rationale for really prioritizing this is that patients often try different approaches to managing their pain and living with it in their daily lives. They know what works best and what doesn't for their unique experiences, yet we know very little about the outcomes of their self-care interventions, and patients actually may be reluctant to share this with their clinician. So I would suggest an actionable strategy to study retrospective and prospective real-world data from patients about the alternative approaches that they're using to live with and manage their chronic pain and the associated outcomes that they've had from those. The second prioritization would be to determine the efficacy of the use of interdisciplinary team in opioid tapering. And I'm going to focus heavily here, hearkening back to the previous conversation and the presentation, that the interdisciplinary team should include patients and those close to them as integral members of this team, that they come into the chronic pain journey from different entry points and experiences, and they can often provide expertise that is not at all represented on the interdisciplinary team. So what we need to do is study models where patients are integrated as true members of the team with very clearly defined roles and responsibilities, so everyone is better understanding what to expect of each other. And ultimately to study peer-to-peer involvement in the interdisciplinary process where patients who've successfully tapered, for example, might be able to share their experiences in a way that actually the entire team can benefit from. And then the last one I would prioritize is strengthening the evidence behind associated benefits and risks of opioid tapering. You know, we've learned a lot about the patient involvement and benefit risks through some of the patient-focused drug development done at the FDA. And I think it's an opportunity to have patients living with chronic pain and those who have gone through the tapering process provide their unique insights into balancing benefits and risks. So really, you know, starting to think through how to develop that patient-informed risk framework for the tapering process would be, I think, a huge contribution to the field. And I'll leave it there and pass it off to my fellow reactors.
Thank you.
Thanks. Okay. Just
Great.
want to thank you for putting the map back up. Thank you.
Of course, it may be helpful for the discussion. But yes, thank you so much. We're now ready for Dr. Rajkumar.
Thanks so much, Aisha. And so I wanted to thank my colleagues, Dr. Houry and Dr. Burstin, for allowing me to comment on your work. I think our paths have crossed before in the past, and just very honored to be reacting to your work. So I just wanted to offer two very high-level thoughts, and then I'll jump to some areas for further thought or development. But one is, I love the construct of this initiative and the construct of a journey map. You know, in the way that I, in my work, often come at problems as someone in the clinical space or as a payer, you know, I don't often get to think about populations in this way. So this is not necessarily disease-based, but it's based on a set of people that share chronic pain, right, which is actually heterogeneous and deeply humanistic, and easily overlooked by the algorithms and heuristics that we use to segment populations right now in the way that we go about things. And so really appreciate the construct. Also think that it really highlights many of the pathologies that afflict modern clinical medicine. So you alluded to the issues of stigma and bias and disparities in access. And we see this so acutely in the management of patients with chronic pain. It is, you know, also you see a lot of provider frustration and burnout in the care of these types of patients. And so it, I think, underscores the immense value of this work and the illustration of a journey. So there's sort of three areas of development or thought that I had. So one was just we talk about the highlighting and description of best practices. And what I wanted to underscore was that in order for this to be useful for someone in my part of the world or the chair in which I sit, what would be the most helpful to me is to have a granular understanding of, you know, if we're looking at a clinical best practice, detailed understanding of workflow, of the intensity of clinical effort that is required, of the speed of particular steps, because that translates into the resources that we need to finance this work. And in almost every panel that I'm ever on, I'm always the voice of the bean counter. And you know, that, as a payer, that's what I am. So my observation is that there are so many important and wonderful things that we can do in clinical medicine, this among them. They often fail because we don't have the right mechanism to finance them and to incent providers to take a journey like this with their patients. And so all of this is to say that in order to finance something, we need a detailed understanding of the resources required and the intensity of clinical effort that's required, and what's the most efficient way to deliver this. And with that information, I can help you think about how we finance this and how we make this real in the delivery system. Some point to that is what exactly do we want the role of payers to be? So beyond financing, most payers, including the public payers, so CMS, both Medicare and Medicaid programs, operate you know, a thicket of rules and regulations, and those rules and regulations can be a force for good, or they can be extremely damaging to the physician-patient or provider-patient relationship. And there are many ways in which policies like utilization management or care management tools that payers operate can be deployed to support the patient journey for a patient with chronic pain. And would be interested to know what exactly we see as the role of the payer in this. And a clear articulation of that, I think, would be immensely valuable for the field. The last thing I just wanted to highlight is something that Dr. Oken mentioned, was that, you know, we have, I think one unique attribute of this field is that we see so many patients that live with chronic pain that engage in self-care, and they try dozens or hundreds of different things. And I have one in my own household, and what I observe is that it's a daily process of experimentation and adaptation, and it's important that the journey of every individual patient contribute to the overall body of knowledge that we have to serve all patients that are on this journey. How do we capture that, and how do we tease apart causality when you have essentially thousands of uncontrolled trials or daily experiments? So it's a really challenging, immensely challenging scientific problem of building the knowledge base of what works, and taking really thousands of different journeys and building generalized knowledge from that. Doctors Burstin, Houry, I want to thank you again for allowing me a chance to comment on your work, and look forward to this discussion.
Thank you so much. And we'll now move to Dr. Walker.
Hello, everyone. Thank you so much for the opportunity to join you and provide feedback. And I just applaud these efforts and wish in so many ways that I had this tool during my own clinical training as a researcher and policy strategist during my time as Secretary of Health and Social Services in my state of Delaware. I have to say, Delaware was the #1 prescriber of high dose and long acting opioids in the nation. And for that reason, this journey really resonates with me. I think having a patient-centered tool that keeps the person at the center is incredibly valuable, and is a great reminder of the way that we have to create these relationships and partnerships with our patients, with the clinicians, and with the health systems. I also reflected that I think there is an important way that we look at the evidence and guidance, but also recognize there are many blurry edges, and it's not a linear path often that patients are on. And so even the word journey, I think, is an important reflection of that need to be flexible, to navigate, to recognize that adjustments will have to happen, and that it is not a one-size-fits-all approach that we often are trained in as clinicians to just say, follow this and it will be solved. Well, it certainly does not work like that, nor does it work that way in policy or large health systems. I think in some ways, we often feel like there are so many barriers at the policy and health systems level, but this tool can really help us focus on keeping patients at the center in a very visual format. So for that reason, I think it's important that we figure out ways to underscore the shared decision making and think about having systems that allow for this flexibility in timely care that is both short and long term, that we think about how to create measures of convenience, and also recognize that there are others that need to be at the center aside from clinicians, patients, and health systems, but also community-based resources and social supports. And I'd love to see those highlighted a bit, or at least maybe as a hover when you click on certain portions of this journey map, that we can bring up additional tools and underscore how those are equal components of a successful journey. I think we also need to think about how we highlight other members of the team, of the clinical team, that really are essential. And I'll always remember talking to some clinicians who I thought would be allies in this, and hearing their pushback that they just were not equipped to handle chronic pain patients in their practices because they didn't have the right people to help, or they didn't have those peer support linkages, and they didn't necessarily have an intermediary to help them work their way into a place where they would be comfortable clinically. And for that reason, we had a lot of barriers in just creating access points that were in communities and in places where people felt comfortable and felt like they had trust and felt like they could engage. And so it may be that part of this map needs to highlight that need for some intermediary for policymakers to support that. And in particular in the state, we found that the role that we could play was paying for peer support managers and bridge clinics to help create a linkage from health system to the clinical environment that really allowed us to increase the access points. So that being said, I also want to underscore that there are opportunities for health systems to also invest in those social determinants, because this journey around chronic pain management and barriers along the way, when someone falls off of the linear path, it often is because of something else going on: economic challenges, job supports, transportation barriers, housing needs. And those may be issues, again, that are embedded in some of the words in smaller print that I can certainly read in my version, but maybe something that we want to figure out how to blow up in an interactive map. I think it appears very clearly under knowledge around how we look at a lack of diverse patient-centric resources, but that may be a way that we could embed additional resources or linkages for policymakers to realize where they can invest, because I think there is a huge role for states to invest in that space. I also think it shows up under support, where it says, this focus on disparities and disparate challenges, particularly around lines of socioeconomic status, where we can find ways to bridge around a diverse set of community partners who can help navigate those social services. I also wanted to highlight for policymakers in particular that the role that they play in addressing stigma is a large one. And again, whether we create kind of an interactive dynamic map that highlights how individual users of this might find ways, actionable ways to actually move forward would be helpful. But I think on the issue of stigma, there are many levers that are well beyond that of a clinician or health system alone that could be emphasized in this middle portion around partnership. Right now it says clinician, but I actually think there's maybe you could add to the lower part of that circular graphic something around policymakers or communication strategy or a public campaign, because the challenges of having people even admit that there is a problem or start the journey has to first start with this acknowledgement that we all play a part in how a stigma around chronic pain is viewed. And I would also like to highlight that the connections to stakeholders, including licensure requirements and other financial incentives, could make this more powerful, because levers around payment that have already been highlighted are critical, but we also know that some of that has to do with state level barriers and licensure around other professionals that can help in this journey, including things like physical therapy, chiropractic care, acupuncture, even in anti-inflammatory dietary management or massage, that are truly policy levers. But if it's not part of Medicaid coverage, if it's not part of how state employees are covered, if it's not part of a conversation with the chambers of commerce and their decision making, I think that is a potential actionable addition that you could make in that middle part around partnership. I also think it's very important when we think about these graphics that people can find themselves in the map in some way. And for patients, they will certainly have a very clear place to go: clinicians, health systems. But again, I think these key stakeholders around community organizations and policy making is critical as a part of the dissemination strategy. So focusing on the equity lens, finding ways to invest in the data that allows you to understand where you have barriers in your region, locality, geography is critically important. And then even linkages or resources around how to use this tool in the dissemination and communication efforts could be incredibly valuable. So I think allowing the map to shift or maybe even highlight additional colors, depending on your identified role, could be impactful. I am not the technologist, so I know there are people out there who know how to do that, but clinicians who are trying to work towards equity or trying to understand what the models of care could be very valuable. And again, policymakers can make some of this happen in very meaningful ways. They can decrease barriers, regulatory, legal barriers, also commit dollars, including Medicaid directors, state behavioral health directors, state legislative leadership and treatment providers. You could think about an anti-stigma campaign that is focused on a tobacco-free like campaign that really is around chronic pain management, could be very valuable. And there are many healthcare policymakers who have a lot of decision-making power around licensure and prescribing regulation and how you insert this into state level continuing medical education requirements that could include this patient journey as an option, really elevate the intersection between the evidence and how we create this journey and pathway. We were trying to explore ways to require academic detailing for those outlying prescribers, but wouldn't it be amazing to have this patient journey at the core of that academic detailing experience, to really create a merger between why they're prescribing so much and where the evidence is and why we need to focus on the patient-centered views. So I look forward to the dialogue together. I'm honored to be asked to provide feedback on this. It's an incredible chance to think about how we create these intersections, and look forward to our dialogue during the rest of the session.
Thank you all so much. That was really extraordinary. And you gave us, I think, lots of good food for thought. Deb, I invite you to join us back in as well and see if you have any questions. I'll just say a couple of reflections I heard is I love the concept that patients can't get lost in the map, that we need to be really thoughtful from Sally's point of view about making sure it's in fact very usable. And I loved the concept that you just shared, that it's not a linear path and that patients may fall off, and really thinking about the importance of where social determinants of health fit in, how health systems and others can help us with that piece was really brilliant. And just very much appreciated as well the importance of recognizing what patients and peers bring to the table in terms of learning, in terms of, I love the concept of sort of day-to-day experimentation and how important it is to share those insights and that real world evidence as we start thinking about what evidence looks like going forward. Was really struck, for example, in the current COVID environment of how much we have really begun to see how much of the insights, for example, around long COVID have been brought forward by the patient community using their own insights over time. So really, thank you for those messages. Lots of important concepts as well from Rahul, thinking about the role of payers, the importance of thinking about workflow efficiency, what that looks like in terms of resources. And I would also add in how they can help us think through how telehealth fits in, is I think going to be a really important role for the payers here. And so much of the comments around equity and thinking about how all that fits in are just so valuable as we think about the next step here. Deb, any thoughts, reflections, or questions?
I think the only thing to add, you've summed it up, is I think what struck me was the workflow and efficiency, because as we're doing this map, we always want to make sure we're including like everything possible we can think of in the different themes, but we do have to consider prioritization and how you would actually tackle some of these things. So I think as we're developing this into more of an electronic format, figuring out how to help with prioritization, payments, streamlining, so that it's clear that you don't have to do all 10 things that are listed. What are some of the key things to consider when you would incorporate these or ask about these?
Yeah, and I also love the concept that this journey map could in fact be used as part of, for example, CME for licensure, et cetera. So thank you for connecting to our prior discussion as well. Any of the panelists have any reflections on what you've heard from each other?
Well, this is Sally. I think I really appreciated the other panelists' perspectives on the integration of this map into real world experiences for policymakers as well as clinicians. And I think doing that is always a challenge to try to make this usable for the various stakeholders. But I actually think if you really begin focusing on, as has been already said, the dynamic aspect of not only the experience, but then the dynamic aspect of this map, and really appreciating that actually reflects in many ways the sort of the lived experience of people, because everything is kind of coming and going in our daily lives. And so the idea of being able to come in and out of this, where the focus might be on one area of your interest that particular day versus another, I think is really valuable.
Yeah, I agree. Other comments? Kara, Rahul? Deb?
Yeah, I appreciated the comments from my co-panelists. I think, again, the idea that we can create these bridge opportunities is important, and just using the visual as a way to communicate with a wide audience is an important part of how we tackle this challenge. I think it'll also be really important, and Sally was much better at highlighting the graphical observations than I was, but I think, just thinking about where disparities, stigma, and bias come in, and having those graphics that resonate with those who are looking for ways to overcome disparities. And, a health system may be looking at how they've tracked their own data, right? But it may be important to say, I'm trying to tackle disparities. I know that chronic pain management is an area that has tremendous disparities, and bias is a big part of why we are not adequately treating pain for a subset of our patients. Can we highlight on this journey map where those levers are? Is it data? Is it finding alternative shared decision-making tools or opportunities? Is it embedding a screening tool in a unique way that eliminates some of that implicit bias earlier on in the intake process? Is it reaching out to our communities where we know disparities exist and saying, if you have chronic pain, we have set up a specialized clinical pathway just for you and your issue? I mean, I think there are many opportunities, and I'm struck by, those memories of these conversations with fellow clinicians that said, I just tell people, no, if you have chronic pain, I just can't take you. It takes too much time, emotional energy, and I just say, I don't take care of you. Well, I think they're saying no because of what Raul said around just burnout and the need to really engage with people around those barriers and around their lives, like how they are constructed. But couldn't we figure out a way to overcome those barriers with some additional strategies, and maybe even, links, and you probably talked about this earlier, some examples of how successful models have moved forward, or how successful pathways have facilitated an improvement in outcomes, or real kind of packaged multimodal strategies where people have created specialized clinics. I don't know what it is, but I think that there are ideas out there, and ways to work with the payers, work with the policymakers to make that more feasible.
I also appreciate the connection to burnout that you raised as well, Rahul. If we can't put resources in clinicians' hands and remove the barriers, it just makes it worse for clinicians, which in turn makes it worse for patients. Any other insights you want to share, Rahul?
No, I think you said it well. You took the words out of my mouth.
Sorry. Trying to be efficient as we keep moving forward here. This has been truly extraordinary. I have like 3 pages of notes. We have a lot of work to do to go back. And again, thank you to our friends at the National Academy for indulging us and sharing the actual visual of the journey map. I think it would have been really difficult to talk about this as Deb and I have been trying to do for months without something to hang your hat on. But keep in mind, this is very early. This is just a way to have this discussion. We will take into consideration all those issues around usability, really thinking about it being a dynamic tool that clinicians and patients and others can use. And thank you so much, I think, for really reminding us back to think about the role of the health system, the payer, and the community and public health organizations in terms of being really important effector arms, and reminding us about the importance of the interdisciplinary team with the patient as a member of that team. Deb, any final words before I turn it back to Aisha? She says no. Thank you so much, everybody. Aisha, I turn back to you.
Absolutely. Thank you so much. What a terrific session with really engaging and thoughtful feedback and discussion today. Thank you all so much. We truly appreciate it. We'll now take a short break. We'll return for our next session at 12:30 p.m. Eastern. Thanks so much, everyone. We'll see you soon.